So Parkinson's is another chronic neurological disease, and we have a lack of dopamine in Parkinson's, and we end up having sort of like a disconnect. We have too much acetylcholine and not enough dopamine. So acetylcholine is an excitatory neurotransmitter, where dopamine is inhibitory. So when you think of the movements that you see with, the way I remember it is like we have too much acetylcholine, not enough dopamine, and what's the hallmark sign that you guys probably know about Parkinson's? What happens? They get what? Tremors, right? So I kind of think of it that way, like it's exciting, you know, their body's excited, okay? So too much acetylcholine, lack of dopamine, so they can inhibit their movement, okay? And again, no cure. So none of these things we talked about thus far have a cure, okay? And the fourth thing we're going to talk about, Guillain-Barré, also doesn't really have a cure. We give supportive care. So all these medications that we talk about are to treat the symptoms. They don't really ever cure the disease. Okay, so this is different because men and women are affected by Parkinson's. Not hereditary or contagious. Okay, the cause is unknown. The symptoms usually begin in the 5th decade. Okay, so the onset is later. We can have early onset, but the onset is generally later. Okay, so disruption of dopamine. Sorry, depletion of dopamine disrupts the ability of the brain to inhibit movement. So we have this part of the brain called the substantia nigra that gets destroyed over time. We have a loss of control of our movements. And there's a pretty gradual onset with this, okay? So like with MS, you might actually wake up one day with facial weakness all of a sudden, okay? And sometimes it goes away and you don't really think much of it, and something will come back a few months later. But with Parkinson's, usually it's kind of insidious, okay? So manifestations. Tremors, like we said, is the big manifestation that we see the most often. If you guys remember, we call it a pill rolling tremor. It's probably the one we see most often, and it's like this. Okay, like you're rolling pills in between your fingers here. Okay. Patients can also become rigid. They can have bradykinesia. Do you know what bradykinesia means? Think about it when you try to slow movement. So they're slow to begin movement. Okay, and they can also have postural instability. So patients may also have gait problems. Okay, be at risk for falls. Okay, so this is called, when patients have what's called a resting tremor. So when a patient goes to do something purposeful, the tremor will often disappear. So it's a resting tremor. Okay, it disappears with purposeful movement, and it's often pill rolling. So it's this function. Okay. There's different types of rigidity, and you don't need to memorize the different names. I don't care about that. I just want you to try to picture in your head when you're looking at someone, you can sort of assess what part of their body is rigid. So you can have what's called plastic, which means stiff and resistant but mild. Okay. There's something called cogwheel, which means they have sort of a rhythmic interruption of their movement, and it can result in a loss of balance. Okay, then what's called lead pipe means total resistance, akinesia, and freezing. Truncal, must move as a unit, chair with arms, old man posture. I always think like Kramer when I think of truncal. He like always turns like this, like whole head and body. You can't just turn your head, turn the entire body. Okay? So truncal must move as a unit. Okay, and then again we have dysphagia and dysphagia. Okay, so that's rigidity. So we have tremors, rigidity. Next is bradykinesia. Okay, so patient may stand with their head forward. We see decreased arm swing, decreased blinking, shuffling gait. Okay, so this is something you'll also see. A lot of shuffling. Okay, ataxia, micrographia. Anyone want to guess what that is? Small handwriting, just like it sounds. Okay. So in addition, patients can have problems with sleeping. They may have problems sweating, flushing, urinary retention, constipation, depression, choking, drooling. Okay. Patients may also walk with a compulsive gait. Difficulty making turns, sort of that trunkle issue, can cause a loss of balance. We tell people if you want to just improve your stability, what do? You're standing on the subway. What's the first thing that you do if you want to improve your stability? You widen your stance, right? Okay, so we teach people to do that. You decrease your chance that you're going to fall. Widen your stance. Okay, so there has been a lot of, depending on what you read and how old the literature is, in my reading it seems like they did not used to think that Parkinson's really affected the brain in a way to cause dementia. But I think more and more they are seeing that there does seem to be an association with dementia. Okay, so it doesn't have to be necessary, but it was definitely something we need to screen for. Okay, what did we say dysphonia was? Hoarseness, okay, and again micrographia. I don't know why I have that twice here. Okay, so you don't need to know the stages, okay? Skip that for now. So diagnosis is generally done by symptoms, and then what they do is they'll do a trial of medication. So they'll give them Parkinson's medications and see if their symptoms improve, and they detect it in the Parkinson's. And again, no cure. Okay, so what are some of the complications? So patients can have aspiration pneumonia from dysphagia, so some problems swallowing. Patients may get weight loss. Okay, why? Because they have dysphagia. Okay, depression. I mean, there's many things that they weight loss. Okay, constipation. We said urinary tract infections. We said they can have retention, breathing problems, skin breakdown. Anytime anyone's immobile, edema, dizziness, and depression. Side effects include nausea, vomiting, decreased appetite, and dyskinesias. Protein diet may help with absorption of medication. So often, it's really that you want the protein to be stable, so you can make sure that the patient is on the right dose of medication. Probably doesn't necessarily need to be a high protein or low protein, but often once we get the patient on a stable protein diet, then we can get them on a stable dose of the medications. Okay, so we have these dyskinesias that can happen after the patient has been on medication for a certain amount of years. They're thought to occur after about 5 years of medication. So what they sometimes do with patients that are on cinnamon is they give them what's called a drug holiday to try to extend that time. Or maybe it's not really important for them to be on a drug and be symptom-free during a particular time period, so they may stop the medication, give them a drug holiday, and then we can elongate hopefully the time that those, before the dyskinesias begin. Okay, so we're trying to decrease the onset of this side effect of the medication. Okay, so if we don't need to be on a medication, let's say there's a teacher, they're at work during the summer, maybe they don't care, they have tremors. So we don't take their medication during the summer, and hopefully over time they'll do that medication more often. So we can also give other medications, dopamine agonists such as Requip. MAO inhibitors, an example is Aldopril, and this can slow progression of the medication, of the disease. So there's something called amantadine, which can be used to decrease symptoms, so it can reduce rigidity and reduce tremors. COMT inhibitors can block the enzyme response that breaks down levodopa. Okay, so it allows the levodopa to circulate longer, stay in the system longer. Antidepressants may be used, and then antihistamines may also decrease tremors. Okay, so those are treating the symptoms, all treating the symptoms really. Okay, so you don't need to know the surgeries. Okay, the only thing I want you to be aware of is that they're really only used if there's like inadequate or no response to medications. Something you may hear about is deep brain stimulation. Has anyone heard of this before? Okay, and I think they can use it for a few different things. Like I said, we're not going to go into this, but basically they use electricity to interfere with the cells that cause tremors. And so they've had some success decreasing those tremors in patients. Okay, so what we're going to do, so one of the things that helps the patient prevent, well, we're going to prevent aspiration, okay, so we're going to elevate the head of the bed. We're going to recommend a wide-faced seat for our patients. Assist with meals, so thick liquids may be better. A high-fiber diet to decrease constipation. Assessing speech patterns, and again, these patients may be in need of speech and swallow therapy. Okay, skin assessment, orthostatics. So why are we concerned about orthostatics? They have unsteady feet. Yeah, so I mean that can be definitely something we consider. They have unsteady gait, and we want to be sure that their blood pressure isn't too low. Particularly, we would be concerned about being too low with their postural instability. Okay, we would always want to ask about sleep patterns. And I would imagine that their symptoms are probably worse when they're more fatigued. Okay? And then, of course, support and coping. Really important for these patients. This is quite difficult because the symptoms become very apparent over time. So they feel like they're walking, the way that they walk attracts attention. The tremor attracts attention. They can also end up with like a facial, like a mask-like faces. Okay, so they have almost no affect that appears when they're speaking to people. So it can be very socially isolating, especially with people you don't know. Okay, so they may think you're disinterested, or they may think that that you're, have some, I don't know what people think. But the interaction between them, with you and someone who has no facial expression, I mean, how does that affect the way that you interact with someone? It affects it heavily, right? You have no idea what the patient's thinking, what the person is thinking. So it can be very socially isolating for them. And especially if they're in their 50s, they're still working. Okay, so this can be very difficult on home life and working life. So you definitely want to make sure that these people get appropriately referred to therapy. Okay, so Guillain-Barré. Any questions so far? Okay, Guillain-Barré. So this is an autoimmune disorder, again, okay, and it's also mild. And you see the symptoms are different than MS. Okay, so again, this is more common in males. So we had MS and myasthenia more common in females, Parkinson's and Guillain-Barré more common in males. Okay, 60 to 70% recover completely. Okay, a small percentage of people will die from Guillain-Barré, and a small percentage of people will never recover completely. Have some sort of residual effect from having Guillain-Barré. Often, this is interesting, often there's a noted risk factor. Okay, so generally it's an infection. You can also see this after vaccines. Okay, we actually had we used to give vaccines at corporate locations, and we actually had a young man who got Guillain-Barré after a vaccine. We don't know if he got it because of the vaccine, it just happened to be within the time frame after a vaccine, and he actually ended up dying from Guillain-Barré. Okay, it doesn't happen very commonly. I'm glad it's not the fall. Hopefully you'll forget this by next flu season. But it does happen. Okay? So usually what we see in patients is they had some sort of illness in the few weeks prior. It's usually a virus. It's usually just a cold. So adenovirus, rhinovirus, whatever. Okay? You can see it in conjunction with HIV. You can see it in conjunction with Epstein-Barr virus, which is the virus that causes mono. Okay, and you can see it after vaccinations. Okay, so what happens is patients get antibodies in the plasma. Okay, and so they have these antibodies, and they end up destroying the myelin sheath. Okay, so again, we have demyelination, and the impulses are slower, the nerves, okay? And so this affects the peripheral nervous system. What is affected in MS? Central. Okay? And this causes ascending paralysis in the vast majority of cases. A small percentage will have initial symptoms up here, but for most people, it's ascending paralysis. Okay, so what happens? We have rapid onset of symptoms, generally in hours, perhaps in weeks. Patients will eventually have weakness of arms and legs. They have numbness and tingling, inability to execute voluntary movement, hyporeflexia or areflexia, so decreased dependent reflexes or no reflexes. Areflexia means no reflexes. Crawling sensations, insensitivity to hot or cold. Okay, so insensitive. Okay, difficulty distinguishing textures. And again, this is an ascending pattern. Blurred vision leading to blindness, dysphagia leading to aphasia. So first they have problems swallowing, then they can't swallow. Okay, palpitations, tachycardia, bradycardia, orthostatic hypotension or hypertension, difficulty initiating urination, incomplete bladder emptying, urinary incontinence, dizziness, respiratory paralysis. That does not affect cognitive function. Okay. So again, this can happen over hours to days and will generally result in mild to total paralysis. And the concerning thing is respiratory compromise, and so this is why they get admitted to the hospital and stay in the hospital for the vast majority of patients. Okay, so think of this as an acute issue. The other things that we've talked about are generally chronic issues. Okay, Guillain-Barré is acute. Okay, so with the Miller-Fisher variant, a small, I don't even know why this is actually involved. A very small percentage of people get something called the Miller-Fisher variant, where they get paralysis of eye muscles. Okay, so paralysis of eye muscles, areflexia, and ataxia are like the 3 hallmark signs of this Miller-Fisher variant. I wouldn't worry too much about that. Okay, so what are the big things with Guillain-Barré? What's the pattern? Ascending, right? So is that top down or bottom down? Bottom up.
Bottom up.
Okay, so bottom up. PNS, not CNS. Myelin.
Acute.
Doesn't affect cognitive. It's acute versus the rest that we've been talking about are chronic. Okay? Most people will go back to their baseline. Small percentage of people die. Small percentage of people will have residual effects. Okay? Why are they admitted to the hospital?
Respiratory.
Generally, it's because they are very high risk for getting respiratory ventilation. Okay? So secondary symptoms include aspiration, they include pneumonia, they include DVT, contractures, risk for infection. Progression usually stops within 2 to 4 weeks. Okay? So for the first 2 to 4 weeks, the patient is where they stay in the hospital because they're getting worse and worse and worse. We're monitoring them, and they're still getting worse. And then usually they hit the plateau period within a month, and then they start to get better. Okay, recovery can take a long time though. Often patients are going to have to go to rehab after. Okay, they were paralyzed. They're very weak. They've lost a lot of muscle tone. Okay, so diagnosis, we obviously think about other possibilities, but we also think really seriously about, was there an antecedent event? Like, what brought this on? Was it a virus? Most of the time it was a virus. Okay? We probably used to see it more with HIV, but now, as you know, HIV is better controlled, so I don't think we see it as much from HIV. And it's interesting, I don't really know, actually I should look this up, what the connection is between, means immune, but I don't know what the connection is directly between HIV and Guillain-Barré. So physical exam, we're going to see loss of knee-jerk reflex. And of course, like we said, ascending weakness, something I didn't mention is that generally it's symmetric, so it's going to be the same on both sides. Okay, history of viral infections. Lumbar puncture, elevated protein levels is what we will see on a spinal tap. And so most patients will end up getting a spinal tap and we'll see elevated protein. Okay?
Do you know why?
No. I've read about it, but I don't remember. Let me think about protein in the CSF. No. Okay, so electrical nerve and muscle test is going to be abnormal. So it would be okay, so no prevention, no cure. Okay, the patient's going to be in the ICU, mechanical ventilation, and this may be elective before respiratory issues progress. So they may do it prophylactically so that they don't have to do it acutely. Okay, the patient will also be put on telemetry. Okay, and as we know, we do anticoagulants often and sequential compression devices to prevent DVT. These patients will not be able to walk, so we can't do that. We make sure they're well hydrated, and we give them SCDs, and we can give them anticoagulants to decrease the chance of them getting a DVT. Now again, we may do plasmapheresis. So we have removal of whole blood with separation of blood cells and antibodies. And then the blood is returned to the body, okay? And again, perhaps IVIG too. Okay, so they they decrease the peripheral nerve myelin antibody. So they have antibodies to myelin. Okay, and so this is removed and then returned to the body. Okay, so patient teaching. Interesting, because this is probably a much scarier event to happen, but in some ways it can even be better than the other diseases we talked about, because the majority of people are going to recover. So I mean, that's one of the big things that we emphasize, is that it's self-limiting and you usually make a full recovery. Okay, but there's severe paralysis and respiratory depression, which is very scary. You never know who's going to recover and who's not going to recover. So the patients will have to be referred for physical therapy and occupational therapy long term. Okay, and supportive care is emphasized. So, as the nurse, so this is the disease out of all the four we've talked about. This is going to be the disease that your patient is admitted for. Okay, so this is going to be the primary diagnosis for your patients. So patients may be on a ventilator. If not, they're definitely going to be doing incentive spirometry, okay, to increase their deep breathing, decrease their O2 trapping. Chest PT, head to side if we're concerned about nausea, vomiting, and aspiration. Suction is needed. Okay, head of bed 15 to 30 degrees. What's that to prevent?
Aspiration.
Aspiration. What else? Breathing. What else? Pressure sores. Okay? So if you're at 90, what's that going to do? Put more pressure there, right? So we want them to be up, but we don't want them to be completely up. Okay, passive range of motion. We want to pad our bony prominences. We know this patient is going to be in the hospital for quite some time. They might even be a good candidate for one of the special mattresses. Okay? Changing positions frequently. Anti-embolic stockings, SCDs, that's something else. Anti-embolic stockings, I didn't mention for DVT, but that's also important. Checking gag reflex before we give patients oral meds or before we give them food. Okay, they will likely need IV fluids. They may need TPN. Okay, so what's TPN versus tube fees? Why are we going to give someone TPN?
Because they can swallow.
Because they're completely MPO and
Yeah, so there's something, so if they, whatever part of their GI system is working, we want to continue for it to work. So if there's something working, we're going to give them tube fees. If there's nothing working, if we need to give them bowel rest, then we'll give them TPN. Okay? Or if they can't, you know, they're ventilated. Okay? So G-tube if swallowing is affected. And of course we want to explain procedures. It's important. They're going to have a million things going on, but we said their cognition wasn't affected. Okay? So we want to explain procedures to the patient. Family support. We can use pictures to communicate. We can use eye blinking. We can use writing. Okay? Speech therapy might be an appropriate referral. Okay? So, primary diagnosis is going to have to do with breathing, ineffective breathing pattern, anxiety, powerlessness, communication. So there's also a lot of psychosocial things that come in here because it's a long period of time that you're cognitively there, but you're in bed, you're being told you're probably going to recover, you're not positive. Okay? Very scary. You can't breathe, you can't move anything. So a very, very scary time. So self-care deficit, definitely, and self-care deficit may carry over to when the patient goes home. So we really do have to emphasize rehab, emphasize the importance of physical therapy and occupational therapy follow-up, impaired nutrition, and impaired mobility. Okay, so we did seizures, right? So what I think I want to do, unless I can play it here or I can post it on Moodle, there's a video of some case studies of MS. that's on the American Association of Neuroscience Nurses that I want you guys to look at. Would you prefer that I post it on Moodle, or would you like to watch it here?
I watch it.
I was here. I remember we met in Neuro. I've been rather much here.
No, I'm not gonna remember.
It's long.
How long?
How long?
It's about 45 minutes.
Oh.
So, you guys, you want to watch it here, or you want to watch it at home?
I think I can watch 45 minutes at
So some
home.
people may watch on their home
They're not going to watch it
schedule.
all for 45 minutes.
I'll watch it.
Okay, so how many people want to watch here?
I have
Raise your hand. I mean, I can just play it and the other people can go. No, but wait, just
Is this the end of the lecture? We have more.
No, these are we did last week.
Oh, okay.
Oh, we don't.
Oh, so that's just not.
So the rest of the
So we're done.